Hi, this is Dr. Ed Kim from the Department of Surgery at UCSF and VA San Francisco. This is part 3 of our acute abdomen module, and we're going to talk about the phenomenon of perforation. When we think about an intra-abdominal perforation, we usually think about a catastrophe. As on the left, we typically think about a patient with large amounts of air under the diaphragm, and on the right, with clinical signs of systemic sepsis, with tachycardia, hypotension, hypoxemia. Typically, we think of somebody who is an extremis who really needs something done very quickly. However, the main learning goal of this podcast is for you to understand that not all perforations are the same. In fact, there's a range from a mild localized infection in the case of a contained perforation to a overwhelming systemic infection with septic shock and often death, which is a result of a free perforation. And before we go on, let's talk about and let's review the pathophysiology that leads to the perforation based on some of the concepts we've discussed previously. The idea is that often these acute abdominal processes started out with an obstruction of the blind luminal end, resulting in distension, intraluminal or wall pressure, leading to ischemia at the capillary level, as in the case of a compartment-like syndrome phenomenon, which leads to weakened mucosal barrier and allowing the bacteria to enter and translocate and cause infection and inflammation, which eventually can lead to necrosis of the wall and perforation. You should also remember that there's a second mechanism which starts directly with the pressure in the wall related to a pressure necrosis of the wall of the viscus and the barrier mechanism, leading to bacterial translocation, infection, inflammation, and perforation. This is typically seen in acute diverticulitis as well as small bowel obstruction with adhesive bands. And now, remember what I said, that not all perforations are the same, and the natural history of diverticulitis is a great example that shows us the different ways or the variety of ways perforations can present. On the right, as you can see, there's a picture of a colon with diverticula, which are most commonly found in the sigmoid colon. And these are basically outpouchings of the colon in the weakened parts of the colon from a diet typically low in fiber, leading to high intraluminal pressures. And these sacs or these outpouchings can can have these small bits of fecal matter or fecalith in them that can apply direct pressure or cause luminal obstruction, which results in localized perforation around the diverticula. On the left, you can see the CT scan. You can see a coronal view that is pretty typical of a patient with acute diverticulitis. If you focus on the bottom of the CT scan, you can see that there's the bladder, which is the oval structure, and overlying the bladder is a segment of sigmoid colon that is inflamed, and you can tell because it has the classic signs of edema, as in the fat stranding, as well as the thickening of the bowel wall, which is a little more subtle, but also a little bit of free fluid just on top of the bladder. It's that triangular little wisp on top of the bladder. Now, diverticulitis presents in a variety of different ways, and this is best described through the Hinchey Classification, which is Hinchey 1, 2, 3, 4. And Hinchey 1 is the most mild form of diverticulitis, which there's some peridiverticular inflammation and maybe small perforation with the pus. Hinchey 2, there's a greater degree of contamination, so there's a larger amounts of response and typically a large abscess, and you can see the abscess on the CT scanned photograph in the left upper aspect of the Hinchey 2 classification, Hinchey 2 class diverticulitis. Hinchey 1 and 2 are contained processes. However, starting with 3 and 4, which are pretty much interchangeable, these two classes are free perforation. One is free purulent perforation, and the other is free fecal perforation, where there's poop all over the place. But in both cases, they're diffuse. They're marked by diffuse intra-abdominal infection with systemic sepsis and diffuse peritonitis. And there's a really nice picture on the CT on the right lower quadrant with all the free fluid in both sides of the gutter and the abdomen. Now the question is, when there's a hole in the colon, how does it not all lead to free perforation and diffuse peritonitis? And the simple answer is that we have an immune system and we actually have a macroscopic defense system. And so when the bacteria gets out after the inflammation, infection in the wall and the perforation, your body is going to respond. It's not going to remain passive, and it's going to send the white blood cells, the PMNs, the macrophages, the fibroblasts. There's going to be inflammatory mediators, lots of activity in trying to fight the bacteria. There's this microscopic activity that occurs. And if we focus on the microscopic activity, I'm going to show you an illustration, and this is a photograph of a mouse that was injected with Staph aureus bacteria in the peritoneum. And the first slide to look at is the A slide, and the dark blue part of the slide is the bacteria. The purple surrounding it is the immune response with the PMNs, and the red material is actually just the intra-abdominal musculature of the mice. And so basically the immune system is trying to surround the pathogen and control it. And on the number on the left, 1 means the number of days after injection. So this is the first day after injection. The bacteria and the white blood cells are basically at war, essentially, or battling it out. Day 3, the fighting ensues basically with a larger segment of necrosis in the middle of the abscess cavity. And day 6, the G in the left lower quadrant, you see this pink rind of fibrinous tissue that is starting to develop. So now this is where when we say there is a more organized abscess that's forming with a capsule or a rind of its own and necrosis in the center. And in J, 15 days, the rind becomes a little bit more hardened and thinner. It becomes more fibrotic rather than fibrinous. So that's the microscopic process at the microscopic level, what's happening. And what I also want to illustrate, and what's a little bit more new to novice clinician, is this concept of a macroscopic response. And what happens is with all this inflammatory mediators, there's a fibrinous deposition which actually makes it sticky. It's hard to explain other than that it's just sticky. And so the surrounding bowel, surrounding omentum, they actually migrate and stick to where there's inflammation. And this stickiness allows is almost like trying to wall off. It serves as a macroscopic barrier response to try to wall off the infectious inflammatory process. And so this is what we'll focus on in the next video. And the next video is a video of somebody with perforated appendicitis, not diverticulitis. And if you look carefully when the CT scans, there'll be fecalith on the left. So let's go to the video. As you can see, on the right lower quadrant, if you focus, there's the beginning of the abscess and there's the large fecalith. And this fluid collection in the middle with the thickened rim around it is a large pelvic abscess as a result of perforated appendicitis. And now when you go in the abdomen, and you can see laparoscopically, the rest of the abdomen is actually clean. There's no pus. It's all been contained. And now, as we enter into this process, you can see how this bowel is supposed to be free. This is small intestine. This is probably terminal ileum. And it's supposed to be free, but it has become stuck to the abscess cavity, or it's become, a part of it is creating the wall of the abscess cavity. And you can see all the pus now being released as the containment. So what's been contained is now becoming freed up in order to suck out all the pus and the bacteria. And you can see the cavity there. You see that thickened rind. That is not supposed to, that is all a result of the inflammation that's occurred over the past several days when this process evolved. So that's an example of macroscopic containment. So what determines when somebody has a free perforation or a contained perforation? And one concept that's very useful in understanding this is the epidemiologic triad, which states that the virulence and the host response and the environment, or the combination of all three, determines the severity of disease. And for perforation, if we were to try to adapt it to perforation, we could say the virulence of perforation would be what is the source? in terms of how dirty the source is. Is it a colon, small bowel, stomach? But more importantly is how much is spilling out and how quickly is it coming out. That'll tell you how big the hole is or how uncontrolled the perforation is. And then the host, how sick or healthy is the host, overall health. A younger person is more likely to mount a stronger defense immune response. Somebody with good nutritional status, obviously, and somebody with an intact immune system. Immunocompromised person or somebody with diabetes may not do as well. And the environment, in this case, would be specific areas of anatomy. Is it intraperitoneal? Is it retroperitoneal? Or is it down in the pelvis where things may be easier to stick to because it's kind of a corner of the body? So if you look at diverticulitis, it is indeed the case that it's a combination between host and the virulence. This is a classic paper from 2005 on complicated diverticulitis. And basically, they looked at the factors that or characteristics of people who presented with complicated diverticulitis. And it was about 337 patients. And what they saw was that mortality and perforation were greater with people who've never had diverticulitis before. And it was also associated with people with steroids, meaning that their immune system was also impaired, and as well as patients with diabetes and collagen vascular system and immune system compromise also had greater association with death. And it is pretty obvious, I think, for most people, it'll be easy to remember that anybody who's has immunocompromised status needs to be carefully managed when they have intra-abdominal process. But what I want to emphasize here is all the patients that have had who perforated for whom it was the first time. So here's a slide from this paper, and it shows that patients who've had no history of diverticulitis, or the ones that were overwhelmingly presenting with free perforation. And I want to clarify, when they say perforation, we're talking typically Hinchey 3 and 4, free perforation, not a contained perforation in the case of diverticulitis. So what it means is that, and what we have learned is that if you have diverticulitis and you have mild diverticulitis, meaning that if your body is able to manage the microperforation related to diverticulitis, you're always going to be able to manage that diverticulitis. So people with recurrent diverticulitis, who've had recurrent diverticulitis that have been mild, we don't worry about them going on to develop free perforation during their hospitalization. However, and that's because we know that the host immune response defense system is capable of managing what happens with their diverticula. However, in patients who's never had diverticulitis and it's the first time, we don't know. We don't know if they're going to be able to manage their intra-abdominal infection or microperforation and be able to seal it off effectively. We do know about 90% of those people typically can, but of the 10% of the people who perforate, who present with free perforation and diverticulitis, those are predominantly their first episode of diverticulitis. So it again illustrates the idea that there's a host factor involved in determining whether the degree of perforation can be contained or whether it ends up becoming a free perforation with diffuse peritonitis. So in summary, I think it's fair to say that perforations of intra-abdominal hollow viscous organs can be a surgical emergency, and I think that's pretty obvious to everybody. But it's also important to remember that the severity of illness and prognosis depends on the amount of contamination as well as the host response, and that the body's natural response is to try to contain the contamination at both microscopic and macroscopic level. And the Hinchey classification in acute diverticulitis is a great example of the variability and the outcomes that can be attributed to these factors that we've discussed. Thank you for listening.